Bismillahirrahmanirrahim. Good afternoon. Assalamu alaikum. Welcome you all to the virtual academic program of Oncology Club, the regular event that we are doing during this COVID era, because we know that we can do social connecting in the era of this social distancing. So today our session, How Should I Treat My Patients Following Evidence-Based Medicine, is on nodal irradiation in breast cancer. And our faculty is Dr. Karthick Raj Mani, who is the consultant medical physicist in the Department of Radiation of the United Hospital. And he will talk about, sorry for the correction, he will talk about the nodal irradiation of breast cancer. And as usual, we have all our three guest faculties available today with us, Dr. Mohammed Zakirullah, Dr. S.K. Paribhai, and Dr. John Conybeare. And we are happy to have our patron and president, Professor M.A. Hai, always with us, and today he is with us. Quickly, housekeeping announcement, it will be a 90 minutes program. We will be having two presentations, and we will have some question answer, quiz, and then we will wrap up. And as we all know, there will be some faculties, the foreign faculties and the local faculties are the postgraduate doctor assistant professors are faculties, and participants are mostly postgraduate physician students and postgraduate physician. And the faculties will be responding to the questions identified by moderator, and we are always encourage the juniors to take part in the question. Quiz is open to all. And we prefer that you send the question in the chat box. So now let us go to the review of last program. Masum, are you there? Regan, Masum is there? Okay, if not there, we go later on. So today we have not done a case discussion. Me and Karthik has discussed the issue, and we thought that we will make a lecture and a practical demonstration type of presentation. So I will take up the first one, like the presentation. It is not a case discussion, but a presentation. But here I will need a volunteer who will be with me to share some experiences. Then we will go to discuss some evidences for nodal irradiation. Then Karthik will give a demonstration how we are doing these things. So it is a bit different today. So may I have a volunteer first who wants to be with me? Anybody? We have 28 participants already. Anybody want to be a volunteer? I shall appreciate anybody coming to volunteer. Please, we want to go fast. We don't want to waste time. We want to waste time in discussion. Anybody? Anybody from old, new? Anybody new is okay. If somebody old participated is also okay. There is no restriction that somebody cannot be the volunteer. Please come up.
Okay, sir. I will be.
Riyadh. Okay, Riyadh. So, we will be talking about regional node irradiation, RNI. So today, we want to share some experience with you. So may I ask you, what do you mean by RNI in breast cancer?
Sir, RNI means regional nodal irradiation. It means irradiation of the regional node, means axillary lymph node, and along with supraclavicular lymph node, along with whole breast or chest wall.
Okay. So, who is the candidate for RNI, you think?
It may, sir, any node positive disease is a candidate of regional nodal irradiation.
Very good. So, do you think there was some change in the indication of RNI in last 10 years' time? I mean, previously there was something, and now there is something.
Yes, previously, indication of regional nodal irradiation was N2 and above disease. But now NCCN guidelines said it is N1 disease also should be irradiated along with.
So do you think that indication of RNI is same with after NSCT and in a fresh case?
I can't understand. Please.
if a patient is having a N1 disease,
Yes, sir.
or a patient is having N1 disease after neoadjuvant chemotherapy. I mean, after neoadjuvant chemotherapy, is it the same indication, or is there is some change in the indication of RNI after neoadjuvant? So it was a N1 disease. After neoadjuvant chemotherapy, it became N0. Will you give RNI or not? That is the question.
If node was cytologically or histologically confirmed, then and if there is no axillary dissection, I should consider.
Okay. So do you think that RNI can give survival benefit?
Yes, sir.
Okay. So do you think that the normal tangent field that we use, medial and lateral tangent, does it covers axillary nodes adequately?
It level 1 and level 2 adequately covered.
Very good. Level 1 and level 2 adequately covered. Fine. So do you draw axillary nodes during breast cancer treatment?
Yes, sir, a few.
Okay, you do. I mean, in limited case even. Okay, I know.
Very
not
limited. Very
so,
limited.
what guideline do you follow when you draw the axillary node, Ria?
Actually, RTOG guideline.
Okay,
As per
you follow RTO. Very good. It is a very good guideline. So, is there any proven role of benefit by using contouring guideline for axillary nodes, or you think that bony landmark, by using bony landmark, if you put the field tangent and supraclavian, it is fine?
no, sir, Mani.
Okay, so we proceed. What is a high tangent field, Ria?
High tangent field we used when we need to irradiate the level 3 axillary lymph node.
Okay, so when you will treat IM node?
Pathologically confirmed or medially or centrally located tumor. Pathologically confirmed internal memory node or medially central or medially located tumors.
Okay, fine.
Or
In early breast cancer,
N2 more than or equals to N2 disease.
thank you. In early breast cancer, can we replace axillary lymph node dissection by axillary radiotherapy?
Yes, sir. We can replace, sir.
Okay, good. Thank you, Ria. So let us come to our today's presentation. So we can see that in breast cancer, it is a funny disease where in T1, T2, there is 10 to 40% positive lymph node risk. And the predictors of positive lymph node is size, grade, high S phase and ratio, high S phase ratio and LVSI. And the risk of internal memory nodes is 1 to 10%. And if we look at the indication of RNI, you see these two books. First was published in 2010 and the third edition was published in 2018. And if you look at the indication in the 2010, they were saying the indication of supraclavicular field radiotherapy for 1 to 3 involved lymph node is less clear. And they have given some instruction that what to follow, when to give these things. But when in 2018, they are telling the supraclavicular radiotherapy is generally recommended for 1 to 3 involved axillary nodes as per updated ASCO-ASTRO recommendation. So this, as Riyadh said, this is a big change. And also the RT is to be given to internal memory if clinically or pathologically positive. So this is a big paradigm shift change between 2010 and 2018. So what are the evidence? If you look at the evidence, the Danish group worked really great job done for breast cancer. And this is the old trial of 82B, which was done for premenopausal women, and where they have shown that the adjuvant radiotherapy gave overall survival benefit. At the same time, they have done another study, 82C, same group of overGERD, and they have taken the patient of postmenopausal women, and they have given tamoxifen 1 year and adjuvant radiotherapy, and even they showed that in 10 years there is 9% overall survival benefit. And in both the study, they have shown that PMRT with RNI has included the local risk of recurrence. And another study was done in Canada, British Columbia study. They have done a 20 years follow-up, and they have shown that there is a survival benefit of around a PMRT has decreased the local risk of recurrence 28 to 10%, and there is a survival benefit. And the benefit was shown in both 1 to 3 node groups and more than 4 node groups. So in summary, we can say that all these three study in long-term over follow-up, they have shown survival benefit. But there are some criticism that the local failure was quite high in this study, and the Danish group, they had mean nodes taken out was only 7. And at that time, they used CMF, and the modern surgical and pathological techniques were not there. So the meta-analysis, we always know that meta-analysis give a level 1 evidence. This EBCTGC 2011 and then updated 2012, they have given a level 1A evidence that post mastectomy radiotherapy to the chest and regional lymph nodes give improved outcome in both 1 to 3 and 4 plus positive lymph nodes. But again, this meta-analysis, even if it's a meta-analysis, they had some limitation. It was older trials meta-analysis, and it was in the pre-screening era. There is a possible stage migration. The systemic therapy used on those time was outdated, and the old techniques was used. So what about some new trial on this RNI? So there are some trials of URTC 229221095 and NCIC MA20 is known this trial, and there is DBCG for IM node. So what this URTC trial? They have done a RCT. They have taken a group of treating with medial supraclav and internal memory radiation. Another group, no radiation in early stage breast cancer. But they have taken both P not and PN, but the 44% of the patient was in PN0. So that was the catch of this study. And they have treated intraclavicular space 1 to 3 average for IM node. And you see they have treated the supraclav and also the adjacent field to cover the IM node. And they have shown that there is a difference in distance disease-free survival, significant, but OS survival benefit was not significant. So the conclusion that local control of axillary node positive patient, but no OS benefit. And in 2015, another study came out. It was named as MA20 study. And there, breast cancer patient with breast conservation, and they have done central lymph node biopsy or axillary dissection, and PN positive and N negative, both high risk group, that is T more than 2 or no more than 5, or if it is more than 2 and less than 10 not removed with grade 3 ER negative LBSI. So they have taken it the high risk group and given adjuvant therapy and or hormone therapy, and they have stratified by giving adjuvant radiotherapy including IM node level 3 and 4, and the dose was 50 grade 25 fraction. And here they have shown that the significant difference was observed in, again, distance disease-free survival, but not significant in OS. So this was a Dutch trial. They have seen the 3,089 N positive patient, and depending on the laterality, on the right, they have taken IM node, and left, they have not taken the IM node irradiation. And they have treated the patient with 48 grade 24 fraction. And they have shown that with IM node radiation and without IM node radiation, there is a difference of local recurrence, which is not that much significant. So overall survival is not that much significant, but they have shown that the breast cancer mortality is slightly higher in non-IM node, but it may not be the effect of the study. That is, if you go to the details of the study, you will see. But the most important thing is in this study, the most beneficial group was more than 4 node groups. So they said that this is depending on the nodal involvement. So if you take all these trials together in San Antonio breast cancer, San Antonio breast cancer meeting, they have made a presentation of the 6th study on RNI, URTC, NCIC, and DBCG, and they have shown that there is strong evidence in favor of regional nodal irradiation, especially when it is pathologically not positive. And radiotherapy to the regional nodes in older studies increase the risk of mortality, maybe due to the radiation exposure to the heart and lung. But in more recent trials, decrease the risk of breast cancer recurrence as well as overall mortality, maybe due to the better techniques. So now let us talk about the opportunity of comparing surgery versus radiotherapy. So if you do a sentinel node surgery, can we avoid extensive axillary dissection in early breast cancer? So this was Z11 trial, and they have taken T1 or T2 N0M0 disease. They have done sentinel lymph node, and for the sentinel lymph node positive patient, they have done one group, they have done axillary lymph node dissection, another, they have not done any surgery, and they have given radiation therapy and systemic therapy. And in clinical, positive node was 420, and SNB alone was done in 436. And it was fairly matched group. If you look at the recurrence, local recurrence is different but not significant in overall. And the outcome, disease-free survival and overall survival, is almost equal. So this study supports the use of sentinel lymph node biopsy for SN positive patient undergoing obesity and receiving whole breast radiotherapy, and not to do axillary dissection. So it is a fairly convincing trial, but there are some caveats. You can see that 46% of the positive sentinel lymph nodes were micrometastasis, and 27% of the patients undergoing axillary lymph node dissection had additional lymph nodes, and 50% of the patient received high tangent. So let us see the variability of axillary coverage. If you look at these two pictures, you can see that we use many superior field for our tangent. If you look at the B, this is normally the cranial edge. Somebody put it slightly higher, and somebody take it up to the bottom, that is A, up to the bottom of the humeral head. So all these are tangent, but as per recommendation, it is said when it is at the level of humeral head or 2 centimeters below the humeral head, then we say it high tangent. So what does it mean? I mean, what is going to change? You see, when it is a normal, 2 centimeters above the breast is the normal, and when it is below the humeral head, it is high tangent. If you look at the level of nodes, normal tangent covers level 1, but hardly cover part of level 2. Cannot adequately cover level 2. To get an adequate coverage of level 2, you need to put the tangent field slightly higher to make it a high tangent. And this was an interesting paper, and they have shown that with a normal tangent, the coverage of level 1, level 2, and level 3 is very poor. Even with high tangent, the coverage is not fairly optimum. So what we are treating with a normal tangent, probably we are missing something. So again, coming back to this Z11 study, it was evaluated that how they have used the field, and they have found that there was quite a variability of the field use, and 50% of the high tangent patient had high tangent or supraclavicular field. So this study result should not be used as an extrapolation to come to a conclusion that we can avoid axillary dissection by radiation therapy. So there was another trial, Amaros, after mapping axillary radiation or surgery. It is a 9 country in Europe, 34 centers. They have taken T1, T2, N0, clinical N0 disease. And out of 4,800 patients, they have done the first randomization, then done the sentinel lymph node biopsy. And after doing the sentinel lymph node biopsy, they have found that 1,600 plus and 1,700 plus was in the both arm, and one group went for axillary node dissection, another for only radiotherapy. If after dissection there was PN2, then they were given for radiotherapy. So this study have shown that there was a advantage in survival. Sorry, there was no difference in the outcome in both the group in 5 years' time. And 5 years data was criticized because it was under powered to come to a conclusion. But in 5 years data, they have shown that the lymphedema was fairly high in the axillary lymph node dissection group compared to the radiotherapy group in first year, third year, and fifth year. And every time it was significant, p-value was significant. So these Dutch gentlemen, they have followed up their cohort for 10 years. And after 10 years, they have said that there was no significant difference between the outcome of both the group. In the lymphedema, they have not done the follow-up after 5 years, and they have concluded RT can be used in lieu of axillary lymph node dissection with lower rates of lymphedema. So AMAROS is a landmark trial which gives us a clue that with sentinel lymph node biopsy, a group of patients of breast cancer, we can avoid extensive axillary lymph node dissection so that the patient will be saved from the risk of lymphedema. So taken together, recent data supports the RNI for high-risk patient with small benefit in outcomes. MA21 ERTC included supraclav and IM node, indicating the inclusion of this node should be considered in indicative cases. AMAROS indicated RT can be used in place of axillary lymph node dissection with less lymphedema. Z1 is a positive trial with some caveats. So what about radiotherapy after NACT? In MD Anderson, they have taken the retrospective analysis of few of their data, six trial patient, and they have found that after NACT, stage 3B and C group of patients are benefited from adjuvant radiotherapy, adjuvant nodal radiation. And NACBP 18 and 27, they have shown that the pathologically complete response group, the effect of regional radiation. And they have shown that if it is a pathologically complete response, the effect of nodal radiation is quite less. So if you look, there are some conflicting data that in MD Anderson, they are telling that only the advanced stage is beneficial, but in B18 and 27, they are saying that there are benefit in all group, but definitely the lymph node positive group is of highest benefit. In B18 and 32 study, they have not used any PMRT, and they have shown that the node positive after neoadjuvant chemotherapy had the higher recurrence rate of 15% compared to node negative group. So it gives a clue that we should be using adjuvant radiotherapy in this group of patients. A trial is going on, that is NSABP B51, which will come to a conclusion that whether we really need to give, who will be the beneficial group after NSCT in this type of patient, that is node 0 after PN0 or PN+. So till then, what we can say that initially locally advanced patients should receive comprehensive regional nodal radiation regardless of response. Residual node positive should receive RNI. Those undergoing full axillary lymph node dissection should receive RT. To the supraclav axillary treatment will depend on residual axillary burden. Sentinel node positive without clinical axillary dissection should receive full RNI, including axillary RT. RNI in those converting to node negative remains controversial, and the current NRG 51 trial will hopefully address this issue. So, does meticulous contouring affect? There's only one slide I want to show that you can see that the normal tangent is not covering, but when you are putting conventional supraclav, it is failing to cover all the nodes in a proper way. So what we want to say that contouring is important to know whether we are missing something or whether we are doing overkill. So there is some debate about hypofractionation on RNI, and the two trial is going on to bring a conclusion about hypofractionation for RNI. So lastly, I want to finish with the correction of our last presentation that I sent a mail to all of you, where by mistake we have added few slides of metastatic breast cancer in adjuvant. And because we want to know that when we are wrong and we surrender, it means that we are honest. And when we are in doubt and we surrender, that means we are wise. So it is good to be honest, but it is better to be wise. So thanks. That was my today's presentation. Now, I think we can invite some question answer, then we'll go to the next session.
Hello, Kamal bhai. Assalamu alaikum. I have a little question. When
Please.
we should use the single modality of nodal treatment, either surgery versus only RT or only surgery? If adequately operation is done and nodal sampling was done, can we avoid the nodal irradiation in N2 disease?
If it is the surgery is done and if it is N2 disease, cannot.
Okay. In the case of N1?
If it is, you see, when we are taking this, only we can avoid the nodal area. Even in N1, they say no. If it is N1, even with after surgery, you cannot. That's why they are telling that to take a central lymph node. If it is central lymph node is positive and clinically N0, there we can avoid it. But nodal irradiation now telling that if it is N1 onwards, you need to consider RNI and then you need to take the consideration of the age, grade, and other factors. But
so we always need the double modality of the treatment, not the single modality.
Yes.
Sorry, I cannot understand.
Achha, come on, right. So that we should consider if N1 onward, we should consider double modality, surgical clearance followed by nodal irradiation.
Clinical. I mean, I understand. You are telling that if it is a clinical N1, shall we go for surgery?
Yes, yes.
For it,
you have
it
to.
is your call.
Clinical N1, you have
clinical to N1. Clinical N1 means nothing. Suppose you done a core biopsy and the reactive changes node could be palpable. A palpable node doesn't mean it is a positive node. So it has to be ultrasonically either FNAC or core proven node positivity preoperatively before you decide. So simply clinical N1, I would be a little bit cautious about it.
But if it is pathological N1?
It's pathological. If it is pathological,
if it is a positive. The Sharif is asking if it is N1, FNAC or core biopsy positive. So can we avoid dissection and go for radiotherapy?
Yes, Kamal bhai, you got the right point.
Yes, sure. Will you base on this, Farid?
Well, it depends. It depends. Sometimes if you think about neoadjuvant chemo, you've done a targeted, you target that positive node with a clip, and then you give neoadjuvant chemotherapy. And in case if there's a complete response, clinical and radiological response, then you can, some places they are offering like axillary SNB at least 3 nodes. And if it is negative, then they are avoiding clearance. Jakuravai, would you like to add anything on top of this? Yes. I was talking about targeted axillary dissection.
Farid is absolutely right. Targeted axillary dissection is a new thing. It's going on trial, and we have been doing it for a long time, almost a year now. Now, it's obviously before neoadjuvant chemotherapy. If you can clearly identify the positive lymph nodes, not more than 2 to maximum 3, but not more than that. So we said 2 lymph nodes will be clipped at the time of ultrasound scan, and then neoadjuvant chemotherapy will be done. And then after neoadjuvant chemotherapy, you just proceed like sentinel lymph node biopsy. But you have to remember that clip node might not be the sentinel lymph node. So we have to remove those lymph nodes as well. And we have got imaging facilities in theater. So as soon as we take it out, we immediately scan them, basically image them, X-ray. And that will tell you that whether this clip is there or not. And then if these lymph nodes come back as negative, then you don't need to go back and do axillary clearance. If the lymph nodes come back as positive, even after chemotherapy, we go back and do axillary clearance. That's the conclusion.
Thank you.
Agree?
But if upfront surgery is done, that time?
After the surgery, just like lumpectomy or whatever you do, after the surgery, we do just sentinel lymph node biopsy in an initial surgery. And if it is negative, then you don't need to go back and do axillary clearance at all. But if it comes back as positive, even after full good response in your tumor, or maybe complete pathological response in tumor, but not in the liver, you have to go back and do the surgery. Yeah.
So Sharif, if I can summarize, the lady is unfortunate that she is paying for an upfront surgery, not sentinel lymph node biopsy, and the 10 node is taken out. Even it is 1 node is positive, this unfortunate lady will be under, as per current recommendation, should get RNI. Because we could have avoided by using neoadjuvant chemotherapy, we would have used it by using sentinel lymph node biopsy, many things. What they are telling, this is the ideal world. But what we see every day, 1 or 2 node positive out of 10 nodes, upfront surgery done, and then we are giving chemotherapy. Then the question is, shall we give radiotherapy? Because it is going to be 2 modality and giving the higher burden of chance of lymphedema. That is the question that Sharif asked. But if it is done upfront, then probably we cannot save. John, would you like to comment?
Again, it's so for the patients who are high risk and have multi-involved nodes, then yeah, post-neoadjuvant chemo, I'll normally do nodal irradiation within my sort of chest wall or breast volume. For patients with who have single N1 disease positivity, post-neoadjuvant chemo, often if they're negative on sentinel node then, or the clipped nodes removed, then often we won't do regional node irradiation, we'll just do the breast or chest wall.
What about upfront surgery, John? No NS neoadjuvant given. Unfortunately, patient gone for surgery first.
So if patient's gone for surgery first?
Yep.
So yes, I will do nodal irradiation on the number of lymph nodes positive, or if they've got less than 3 and they've got high risk factors, big tumor, triple negative, lymphovascular space invasion. So that will, again, make me consider irradiating the nodal regions as well.
So we can sum up that if it is an upfront surgery done, if there is node 1 to 3 positive, then we need to think about nodal irradiation, and then we need to consider other tumor biology to decide very cautiously that what we are going to do. Are we going to include supraclav or not, or I'm not? That is the summary you want to say, John?
That's correct. Yeah.
So not for all the patient, we should go for renal nodal irradiation of PT1, 2, or N1 disease. But for the patient like high risk, intermediate risk, and low risk.
We need to think of, but it is not every patient, but we need to consider the age, risk factors, then we need to think. Before it was not that much recommended, now it is recommended, but again we need to consider all these issues.
Kamal bhai, this is recommended, but all the 4 big trials. Kamal bhai, are you hearing me? Yeah, this is recommended, but all the big trials like French trials, MA20, and Danish trial, all are failed to show any survival benefit, overall survival benefit.
Exactly.
There are some disease-free survival. Yeah. Should we give all the patient we should offer all the patient the nodal irradiation of early stage breast cancer?
No, we should think of nodal radiation, then we think the tumor biology,
benefit and risk also.
Everything. Then we decide. It is not a plain yes.
Some risk factor, consideration of some risk factor also.
Yep. So any more question?
Yeah, I have a question. Is there any indication of RNI in N0 disease? N0, but N0. Indication of nodal irradiation?
I don't know.
Yeah, there is a indication in NCCN that is the tumor is more than 5 cm and margin is positive. Even though it's N0, that's they recommended for nodal irradiation.
The question is, what does it mean? RNI means level 1, 2, 3, or supraclav 4 or IM?
Supraclav and internal memory also. If it is more than 5 cm and margin positive, margin positive, then N0 node, they recommend the RNI also.
It is not, I think it is only axilla, not IM. Lima, if I am not wrong.
No, it's supraclav. It's supraclav also.
Only supraclav, not IM.
Supraclav also.
Yeah, I'm a bit confused. I mean, you were saying that the margin is not complete. You're talking about after mastectomy, or you're talking about
mastectomy?
Yeah, it's N0 node, but that's indication of nodal irradiation. in case of more than 5 cm tumor or margin positive, it may be post-mastectomy.
Post-mastectomy.
Or
it is post-mastectomy.
Right. So
So
I
that
thought
date is
post-mastectomy they have to do chest wall radiotherapy. I didn't know that they have to give supraclavicular radiotherapy.
no, nodal irradiation. I'm talking about nodal irradiation.
John, we need your help as well. Just to clear my
the
mind.
problem is in NCCN, they are telling that if it is T1, T2, N0,
Yeah.
post-mastectomy, you can avoid
Yeah.
nodal radiotherapy. But if it is margin positive or the T was more than 5, that is just marginally not T2, then you can consider of radiation along with nodal irradiation. So I remember what Lima is telling. But again, the question is, this group, they are telling that there is a subgroup of patients who may be benefited even in this type. So, this nodal irradiation in breast cancer, I think it's an extremely gray zone. I mean, there is no 2 + 2 = 4 story in every situation. So we need to, things are changing, but not having a very clear-cut conclusion. Okay.
It's not practiced in UK. Kamal bhai, it's not practiced in UK.
No, that's I'm just very surprised. I mean, I know this is a study. I completely understand, but I think did they show you the survival benefit or overall benefit or in local benefit or anything like that by doing supraclavicular?
It is only local control. As she was telling, that RNI is not even this early stage they are showing, and is heavy burden patient they are showing survival benefit. The early this is small issues, it is showing only local control, not giving any survival benefit.
Okay.
Again, I think IMC, I consider myself quite cautious when it comes to IMC irradiation, simply because I'm conscious of the fact, again, it has no definitive survival advantage, but we do know clearly that irradiating the heart leads to a significant morbidity. So again, it's something that it's considered, a considered decision.
John, can you tell me exactly what situation I am?
So I'm about to plan a lady now who had obvious PET-avid disease within her IMC, pre-neoadjuvant chemotherapy. And all patients where they've had staging, they've got involved IMC nodes on their staging scans. I will obviously treat those patients. And again, heavily node positive. So the upper reaches of N2, N3 disease, I'll include those patients.
So the message from John is, even we should not be tempted with the recommendation of IM node, because we don't know, maybe 20 years down the road, we will hear some new story, because by treating IM node, whether we are doing harm or benefit to the patient, because as he said, especially in the left-sided breast, even on the right side also, when we are treating IM node, even by electron, we are really doing some amount of dose to the heart. It is not zero dose. So IM node, we should be very cautious when we are thinking of IM node. It should be treated. I mean, what is still the majority practice is when it is pathologically positive, or when there is heavily burdened disease N2, N3, or even of the neoadjuvant chemotherapy, there are so many positive nodes that it is a really heavy burden. Then we can think of IM node, because to treat IM node is a very tricky thing, and it is I think one of the most difficult thing that Karthik will be sharing with us, that how difficult it is to treat an IM node in breast cancer, both in whole breast and also in post-mastectomy status. Any more question or comment?
Yeah. So modified change in macros.
There was a question from Silet. Dr. Isfar, can you please unmute yourself and ask the question?
Kamal bhai,
yes.
Can you hear me?
Yes, I can.
After axillary lymph node dissection, if there is residual disease, can I consider nodal irradiation in only residual?
Yeah.
Is it after NSCT or it is not after?
In both cases.
No, if it is not NSCT, why should we do residual? It is not positive or not negative. Residual is if it is after NSCT.
Residual after NSCT?
We do a lymph node dissection up front, and if there is a node, if the number is 1 or 2 or 3, then we can think of regional node radiation with considering the biology of the tumor, risk of the patient. But if it is more than 4 or more, then definitely we should. But the question comes after neoadjuvant chemotherapy, if there is a positive node, then there is recommendation of giving regional node radiation. But if it is N0, which was N plus by sentinel lymph node biopsy pre-chemotherapy, then there is a debate, and majority says not to give, but the BM51, the study that I told, is accruing patient that will come to a conclusion that node positive pathologically before neoadjuvant, which become PN0 after neoadjuvant, whether they need regional node radiation or not. That study is taking care, but till now, there is a scope that you can omit.
Could I add something?
Yeah, please.
Yeah, his question was, should we give nodal irradiation to some residual disease in the axilla? Whether it is after neoadjuvant or upfront surgery. If there is some residual disease in axilla, we have to give include that in our target volume when there is an inadequate surgery in the axilla. This is the indication of axillary radiation or nodal radiation.
Kamal, can I come in? I'm a bit confused about two comments. One is inadequate surgical treatment.
Yeah.
Can you define what do you mean by inadequate surgical treatment in axilla? And number two, can you also define residual disease volume after axillary clearance? So can you clarify this first?
Lima.
Shahida?
Yeah. So what was Istu's question? That was residual disease after surgery.
No, you commented, you said two things. One is inadequate surgical treatment in axilla. What do you mean by that in axillary clearance?
Sometimes
you also mentioned, and second question I'm going to ask is, what do you mean by radiation? Like, well, let's start with, what do you mean by inadequate surgical treatment in axilla?
Sometimes we get a patient with report like that 5 lymph node was excised and out of 5 is positive out of 5. That time we considered the patient as inadequate dissection. 5 out of 5 positive or 4 out of 5 positive. So that time we also include other part of the axilla in our radiation field because there's not adequate axillary dissection. Okay.
For a standard axillary clearance, you have to have 10 lymph nodes.
Positive
the sample. That's at least 90% of cases, and that's a standard. So if it is a neoadjuvant chemo, often we identify that post neoadjuvant chemo, if you do axillary clearance, often you may not be able to see 10 nodes. And this is kind of almost routinely seen when we do axillary clearance post neoadjuvant chemo patients. So how would you define that, whether it's an inadequate surgical or there is a residual disease volume? Because I don't understand that the concept of residual disease volume after you have done an axillary clearance.
No, that was his question. So my question also is, how did he assess that the residual disease is there? Sometimes inadequate surgery, we understand that this is not adequate number of lymph nodes coming out, but Stu? Are you here?
Upfront surgery is done. Upfront surgery.
Upfront surgery done, and how did you assess that the residual disease was there?
By imaging.
Imaging. There was a lymph node there.
Yeah.
What does it mean?
You should go back and clear the axilla again. I mean, if you find out that you have done inadequate surgery, initially probably thought about taking some lymph nodes out, not an expert in axillary clearance. I completely agree. In that case, if you find out that you're a good surgeon, you should go back and take all these lymph nodes out as much as possible. Because in my opinion, axillary surgery is an art. Everybody has to know how to do it. All breast surgeons know how to do it. And if you leave anything behind, it means that you are not a proper axillary surgeon. That I can conclude in that way. So you should not be doing it. Second thing is, as Farid said, I completely agree. If you're after chemotherapy, sometimes 3 lymph nodes came out. I'm doing this axillary clearance for many years, and I do exactly the same landmark. I've retrieved 79 lymph nodes at one point for one patient. I was really surprised. How did I do that? And another patient, 59. And And another patient, I got 3 lymph nodes after chemotherapy. So it's not the surgery. Don't blame surgeons. That's what I'm trying to say, that inadequate surgery. If you think that this has got 5 out of 5 lymph nodes positive, it's done proper axillary surgery, then I agree that this is a nodal burden, you can say, rather than inadequate surgery. That's the terminology is not right. Do you agree, Farid?
Yep. Thank you.
Okay. Now carry on.
So I have a question to Farid and Zakirullah Bhai, that is there any benefit of taking out more than 10 nodes in axillary dissection? Is there any survival benefit?
I think what we do axillary clearance. Zakir Bhai, you go ahead.
Yeah, no, you tell. Farid, and I'll add to it.
Zakir Bhai.
Zakir Bhai, go ahead, please.
Okay. Now, question is, 10 is an arbitrary term. 10 number has been included when everybody is trying to say, okay, I have done 49 lymph nodes and my colleague is doing only 5 lymph nodes or maybe 12 lymph nodes, so they're not doing proper surgery. So this is an arbitrary term has been used as 10, minimum 10 lymph nodes. So most of the times you have seen 80% or 90% of the cases, when you do axillary clearance, 10 lymph nodes are actually taken out. And interesting thing is, it's not how many lymph nodes you have, because we don't count lymph nodes. The pathologists are counting. It depends on who is the pathologist. I've seen my good pathologists, when they've got training, they count more than 30, 40 lymph nodes. But when they are frustrated and tired, they just pick up a few lymph nodes and then say, okay, fine, I've done 10. So it's for guidance for the pathologist as well, that please at least take a look for 10 lymph nodes so that we can say this is adequate axillary clearance. For it, you can add now.
Thank you. Perfectly said. One thing we need to understand that we do not cherry pick nodes from axilla. That's not the way to do axillary clearance. There are certain way we have to define the anatomical landmarks and preserving all these important structures like axillary vein, long thoracic nerve, thoracic neurovascular bundle. You preserve them all and you take the remaining fatty tissues out. And if you take those fatty tissues behind pectoralis minor, then you go level 2. And often you do not need to go level 3 unless there are suspicious nodes going that far level. And within that fat, it gets sent to lab. Lab will wash the fat off and then harvest all the separate nodes. And that's when they will tell how many nodes are there. So it is a retrospective. The number 10 counts after the pathology report, but not during surgery that I've done 10 nodes and my job is done. That's not the way we should be operating.
Okay, so
I have a question.
Sorry, and let me sum up this question, then you take your question. We can sum up that we want to address only level 1 and level 2. We want to take the representative center sample of level 1 and level 2, and it is understood that if at least 10 number of nodes is taken, that will give us a guidance for our future treatment, that it is adequate lymph node is taken out, and that will give us a treatment prognostic and treatment related. But it is not going to give us any curative benefit that more node taken is more disease taken. It is not. So that is another caution, that going up to level 3, it is a very special situation where there is indication of taking level 3. Surgeons like Farid and Zakir Bhai, everybody, they are always targeting level 1 and level 2. And it is said that it is understood that at least 10 number is fair enough to make a representation of level 1 and level 2. And this will give us a clue that shall we treat supraclav, shall we take IM node, and also a prognosis of the patient. And it is not going to give any curative benefit to the patient by taking out the number of nodes. So this misunderstanding should not be there. And regarding the residual node, is to let me make you very clear that once we know that this is my target, then we need to know which level we are going to treat. It is level 1, 2, 3, 4, or IM. So that will guide us on the basis of the number of node positive, tumor biology, tumor size, age of the patient, everything. Once I decide that I want to treat level 1, 2, and 3, then I need to shape my field in such a way that I have covered all the 3 nodes. Yes, what Lima was telling, if there is a good surgical clip is kept behind, definitely we will see that that area is covered. But if it is no such clip is there, we need to base on the knowledge of our anatomical contouring of the nodes, and then we need to cover with the adequate nodes, that is with high tangent and at the matching supraclav, what Karthik is going to show us, which will ensure us that 95% was prescribed dose has covered the level 1, 2, 3, and the suprainfraclavicular, and level 4 also, when we are taking the supraclavicular and suprainfraclavicular node. So this is the factor is we need to decide when we want to treat which area. It is not that I have some node kept behind. This is not that important, rather than the guideline that we are following, that which will guide us about the nodal irradiation. Now there is a question from Debraj, then I think Riyad you can take. Before there was a Debraj Chakraborty wanted to ask a question.
Thank you, sir. Am I audible?
Yes, please.
Thank you, sir. I have a question that what is the indication of posterior axillary boost?
Yeah, posterior axillary boost. I think Karthik, are you going to cover it?
Posterior axillary radiation.
Yeah, I'm going to cover it. Don't worry. I'm going to cover it.
The Karthik will cover. It is a very important. We need to have posterior axillary boost when we need to have adequate coverage. And Karthik in his presentation will cover it. Okay.
Yeah, sure.
Thank you, sir.
Riyad, your question.
Okay, sir. Thank you for giving me a chance. Sir, my question is, should we consider regional nodal irradiation in a postmenopausal lady with T2 tumor, like 3 or 4 centimeter tumor, ER positive, with surgical axillary staging done, no sentinel lymph node was found showing tumor, and adequate lymph node, and patient was grade 1 ER positive. Should we consider regional nodal irradiation in this case?
No.
I think we discussed this one.
It doesn't satisfy the indication of regional node irradiation. Riyad, if I am not wrong.
Okay, sir.
Any more question or comment? Then otherwise we go to
LVSI is also important for this. LVSI.
Yes, sir, ma'am. LVSI positive. Because
LVSI positive.
LVSI positive, but ER positive, grade 2, grade 1 or grade 2. Tumor size 3 or 4 centimeter, postmenopausal lady.
Yeah, no. LVSI is one of the risk factor for
but should we consider regional nodal irradiation only on the basis of LVSI, or we can spare it?
You can spare. You need to have at least 3 to 4 factors when you don't have adequate node positive. In node negative, with this risk factor, it is not recommended. If adequate dissection is done, then there is
no dissection is done. Only surgical axillary staging, no dissection.
What do you mean dissection? What do you mean by staging? Riyad?
Sentinel lymph node biopsy. Sentinel lymph node biopsy was done.
Yeah.
No,
they said negative.
Sentinel lymph node negative, sir. Negative.
Okay, that's fine. Yeah. Farid, you had a comment. Farid.
Okay.
Thank you. Is this question in relation to prime to trial? Yes or no?
Riyad, are you relating it to prime to trial?
No, sir.
No.
Okay. If the sentinel biopsy is done is negative, there is no point doing irradiation to axilla, SCF, or IMNL, but obviously to breast. So we have to be careful about using the term regional nodal irradiation, because that covers a lot of area, includes breast or chest wall, axilla, SCF, IMNL. So if you just keep using the same term, it could confuse all of us. So I would rather suggest, instead of using the term RNI, when you talk about individual patient scenario, specific area should be mentioned. Where are you going to offer radiotherapy? Is it the breast you're talking about? Is it axilla, or is it SCF, or is it all of it? So I think
axilla.
That would probably be less confusing. Thank you.
I completely agree with Farid, because we always mention some patients might need only regional, means only axillary radiation. Most of the times we don't actually give that much of a radiation to axilla. We give supraclavicular or IMF normally, intermammary group. Now, just to correct with Shahida, I mean, I completely agree with Shahida. I'm not actually criticizing about surgeons, because I've seen that axillary dissection is one of the surgery that is very badly performed. Not only in Bangladesh, it's badly performed some places in the UK as well, because I've gone through training program and I've seen different consultants are doing it completely differently. So you have to have a standardized policy how to do the axilla. Once you learn that, then everybody can be certified that they are doing proper axillary surgery. But in Bangladesh, I completely agree that some people are actually doing cherry picking, completely not doing the proper surgery. Okay.
So for the benefit of doubt, most of the time we have to give radiation to such type of patient. very inadequate result, especially from the periphery.
Okay, so may I make
Kamal, hello, Kamal. I'm getting totally confused. What is the message? Take home message.
Sir, take home message is, sir, that normally in normal tangent, we are covering level 1 and part of level 2. If there is no indication of auxiliary radiation, that is the N is 0, that is clinically N0 and pathologically sentinel lymph node negative, or on dissection it is N negative, it is fair enough. It is breast conservation or mastectomy. We don't need to treat the axilla. The moment there is a sentinel lymph node positive, and then we start thinking about the axillary nodal radiation. So axillary nodal radiation, the moment we say, that means we are adding the third field, that is the supraclavicular field, which will cover level 3 and also level 4. We are not thinking about internal memory nodes. So axillary nodal radiation will come, sir, when we have a definite proof of pathological nodal positivity. And we can avoid it if it becomes negative after neoadjuvant chemotherapy, either by central lymph node or by dissection. So this is the thing. And internal memory node, okay, for it, let me finish, then I am coming back to you. Internal memory node is only practiced when there is an obvious proof that it was PET positive or pathologically positive, or it is N2, N3 extensive burden disease. Then with axilla, that is tangent supraclav, we add the fourth field, that is the tangent. And in the presentation of Karthik, he has a wonderful slide I have seen from Australian. They have given a clean-cut indication when we will treat level 1 and 2, when we will add level 3 and 4, and when we will add IM node. Because this is the area, as Zakir Bhai said, or Farid said, if I say RNI, it means many things. Even if we say axilla treatment is a funny thing. I mean, axilla is level 1.
I have already heard all the lectures,
Kamal Bhai,
yes.
Can I have the chance to
Not at all. I do not want to listen from anybody else. I want to finish this chatting.
Okay, sir.
Go to the next year. All the time, linking with the same thing, you are discussing all the time.
Okay, sir. We will be covering in the next presentation this. For it, there was a comment.
That's a different context. I'm not talking about, sir, I'm not talking about this. I have a different scenario for all of us. So due to patient choice, someone had a mastectomy and axillary sentinel node biopsy. Now, the histology is 2 centimeter grade 1 invasive ductal cancer, 1 SNB is positive. Now, what radiological treatment, which area would you recommend?
Farid Bhai, so one node is sentinel lymph node biopsy positive. So the second question is, it is micromesh or macromesh?
Macromesh.
Okay. If macromesh, then we have to see the adverse factors like tumor size, if it 2 centimeter or more, LVSI grade 3, age less than 50.
No, don't say these things. I'm giving you scenario. Yeah. Just answer it quickly.
According to if there is no adverse factor, then modify tangent. Okay, including only the level 1 and 2. And if adverse factor is there any adverse factor? I missed that part. Any adverse factor?
No. Simple thing. Simply, there is no adverse factor. It is a grade 2 invasive ductal 2 centimeter cancer, but patient had a mastectomy because patient wanted a mastectomy, and sentinel node biopsy 1 sentinel node was positive. So I'm just asking a simple question: which area would you be irradiating? Don't ask me any more questions. Just what is your comment?
But I have to know LVSI is positive or not. EC is there, or ER positive or negative?
ER positive.
Yeah.
No LVI.
No LVI.
ER positive. HER2 negative.
So I will consider only the modified tangent that includes just level 1 and 2 axillary nodes. No additional fields.
Current practice is, even if the cancer is small, the chest wall needs to be irradiated as well alongside axilla.
Yeah. With chest wall.
Nodal positivity.
Chest wall level 1, you include the level 1 too. Yeah, chest wall with chest wall. The level 1, 2 should be included with modified
doing axillary clearance.
No. Yeah. If SNB is one positive node, there is no need to do clearance.
Yeah, no clearance.
The question was, what adjuvant radiotherapy, which area needs to be covered? As Shahida rightly said, axilla needs to be covered, but then chest wall needs to be covered as well.
Yeah.
That is the current practice we've been doing for last 2 years.
I've got a little bit of question here, because you took only one lymph node and that came back as positive. How do you know that the other lymph nodes are not positive?
If you look at the average of SNB is done, average is 2.1 or 2.2 nodes. But when you do an axillary SNB and you found there is only one node was giving isotope signal and there is only blue node and there is nothing else, would you want to do any more? Why you have to?
No,
it's a standard practice.
You take one. I completely agree. Of course, you take one. You don't have to take two lymph nodes at the time of sentinel node biopsy. But if subsequently you find out that one lymph node is positive, will you consider doing axillary clearance? Because that's the question. Because I think if you follow Zulu 11 thing, you might not. But some of the centers are still doing axillary clearance, including our one. Even if one lymph node is macrometastasis, you go back and then do axillary clearance and then decide how many lymph nodes are there. So, John, you can add. Because it's not straightforward.
I'm surprised. Yes, no. I'm really surprised.
Even in England, it's going on. So that's what I'm saying. John?
Yeah, no, in our MDT, they will go back and do clearance for patients with N equals 1.
That's what I'm saying. So it's not universally accepted, Farid. So yes, of course, there's an option that you can do radiotherapy, but if you follow the Z11 protocol, but we are still not in the form of Z11 totally. So that's why we're still doing axillary clearance. And sometimes without surprise, we can actually get more lymph nodes involved. Although most of the 70-80% of the cases, you might find only one lymph node out of 10 or 20 you have taken out. But I've seen about 10 to 20% of the patients, they have got more lymph nodes than what you expected. So we are still doing axillary clearance.
So none of the hospitals in Oxford, whole Thames Valley region would recommend going back to do axillary clearance. That I can guarantee you.
That's what I'm saying. It varies.
That was an interesting topic I just wanted to raise.
And I completely understand for it. I'm not saying that, but it's not a universally accepted thing. It varies from area to area. Once we'll get a proper study from our PREDICT and other studies, like Zoo 11 is fine, but not there's.
You're talking about POSNOC, not PREDICT. POSNOC, right?
POSNOC. So then we'll understand. Okay, thank you.
Okay, so we move to our next presentation. Karthik, would you please start? Nodal irradiation radiotherapy. Karthik.
Yeah, good evening. I think, it was too hot. So I understand it's a very controversial area. Like when you come into the breast, when you talk about nodal irradiation and obviously surgery, it's something about, really a lot of controversies are there. Anyway, my area is simply, it's clear. I'm just focused on nodal irradiation breast radiotherapy, so that, not much controversies in radiotherapy component. But yeah, the selection criteria makes a lot of difference. Where to treat and where not to treat, it's purely the clinician component. But as a physicist, I have a luxury. Just, if I have my CTVs and PTVs, I can go ahead. Okay, let us start with contouring guidelines. Normally we have a standard RTOG and ISTRO guidelines, and there are new additions like the RADComp and the PET Labrador, which also came with an evidence-based contouring guidelines. Really, they work it on the recurrence pattern, and they added a lot of area which is missed by the ISTRO and RTOG guidelines. So that really people can look into it. Really, it is interesting to get into this too. Contouring guidelines. Really, it will help us to improve the contouring guidelines and improve our contouring. For example, in this slide, it's an contouring variation between the different guidelines. It's I can show in a different colors: ISTRO, RADComp, PET Labrador, and ISTRO. There is a difference. Obviously, there is a difference between different guidelines, but at the end of the day, you can see evidence-based really works, so that if you can see this is a mastectomy cases. Here also there is too much of a change, but if you see the RADCOM, which is based on evidence, you can see that they went too much towards the posterior for the level 2 axilla, so that they really care where the recurrence happened. So they incorporated these areas. So that breast nodal irradiation, when you come to ISRO guidelines, so normally we mark as the Dr. Farid and Dr. Zakir told, we have to be very clear about when you talk about regional nodal irradiation. Yeah, whether we are going to give to level 3 and supraclav or level 1 and level 2, we have to be very clearly mentioned. It's not like I will do a regional nodal irradiation. We have to be very clear where you're giving. Okay, so that there are different circumstances. Normally we can start with if with eastro guidelines we have the yellow color here mentioned is the level 1, and we have a level 2 and level 3 axilla, and the supraclav starts, and you have an intramammary chain also, so that these all 4 components will, the axilla, supraclav, and the intramammary chain, this makes the regional lymph nodes for the breast patients. So that here, the normally in the eastro guidelines, the instead of supraclav, they put it as a level 4. The main reason is they don't want to confuse with the supraclav field of head and neck patients as well as for the breast patients, so that they put it as a level 4, which is the supraclavicular nodes. So that the level 1, level 2, level 3, which clearly mentions the 3 levels of an axilla, and the level 4 mentioned here, the eastro guidelines is mentioned for the supraclavicular node. Okay, and it clearly, obviously, this all guidelines are 100%. We when you go with an evidence base, it's not always right when you go with these guidelines. Okay, this is a paper which is published in 2019 and in Red Journal for the clinical investigation component. What they did is, in the center, it's a single center study. What they did is from 1998 to 2013, the 15 years, they found out all the patients who had a nodal recurrence. Just they map it on CT images. Okay, it was a very interesting study. You can see the amount of a recurrence pattern. This are the dots shows us what are the recurrence pattern in the different levels of your axilla, intramammary chain, and the supraclavicular node. You can see here, and most of them, it occupies the posterior part of your axilla, as well as you can see some of them are intramembrane chain, and most of them are in the posterior part of your axilla component. So that they found that all these 243 patients, they found the relapse of a nodal recurrence is 42% of the axilla cases, and in the intramammary node it's around 32.5%, and the supraclavicular node is around 25.5%. Okay, it is really interesting. Okay, and when you compare with the guidelines, and the ISRO and RTOG guidelines really covers 82% of this nodal recurrence area. That was good, but still we miss around 18%. Okay, so that the majority of the of the field nodal recurrence compared to the ISRO and RTOG guidelines, if you see the RTOG guidelines, which stands 45 out of 30, which is 6-7%, and the ISRO guidelines, which is around 89%. Okay, so that if you do RTOG guidelines still, and as well as if you do ISRO guidelines, still there is a chances the reason they quoted out is due to the daily setup movements and not enough margins. Okay, this may be the real pictures, or most of the times we giving underdose towards the posterior part of the axilla. That may be the real reason, and towards the lateral margin also. It's very important when you try to do the image guided radiotherapy is going to be have a clear picture, whether these 3 patients are treated with on daily based image guidance. That is also more important to understand. And the other component, which is the lymphovascular invasion, what we're discussing during this surgery component, that is also associated with the intramammaryal node recurrence. The presence of an intramammary node, it's a significant overall. It affects the overall significant overall survival. So that with has an auxiliary node for 5 years, if you have an which is something about 59% and 72%. Okay, so that the rationale of the regional node irradiation in breast is still it's an indisposition part of an adjuvant therapy in the patient of a lymph node positive, whether it's an earlier breast cancers. The role of an a regional node irradiation for a patient with breast cancer remains controversial, particularly on the basis of nodal involvement. It has a lot of other factors to be included, and the data from MA20 trial URTC and have proven that additional of supraclavicular and intramammary lymph nodes, it's effectively improve regional and distal control as well as a disease-specific modality compared to the whole breast or chest wall irradiation alone. Okay, I think this is the slide, just Dr. Kamala showed, just I want to clearly show it. Obviously, there is an, advantage of regional node irradiation. like, for a loco-regional recurrence, like, if you don't do an RT, and with RT, we have a significant advantage, somewhere around something about 17% for the recurrent first recurrence, and which is about something about 8% to 9%. And overall breast cancer mortality, we have something around 8% with RT and without RT. And if it is if it is pathologically more than 4-node positive, okay, here also, like, the loco-regional, which has a difference of something about 27 to 30%, and the loco-regional recurrence first, and any first recurrence, which has an advantage of something about 9%, and overall breast cancer mortality, we have a difference of around 10%, which is substantial. And like, this is I took this from an New South Wales like guidelines for the breast nodal irradiation evidence, and they have an guidelines of supraclavicular fossa and level 3 involvement. When you will irradiate supraclav as level 3, the recommendation is pathologically T3 and node positive, PT4 any staging, and PT any N2 and N3. Okay, and like, considered for pathologically T1 and 2N1 and PT3N0, depending upon the presence of additional risk factors. Okay, regarding the like internal memory chain, the independent benefit of IMC coverage is still, as we discussed, it is not certain. Okay, like, when you go with an IMC, it is not always certain you're going to benefit the patient, but IMC may be strongly recommended if it is N2 positive or medially located tumors. Additional risk factors for loco-regional recurrence include the presence of LVI, and it's a high-grade tumor, young age, there are a lot of loadal burdens, and multifocal or multicentric tumors, and ER negative. Okay, this is what Dr. Kamal was talking about when you will give the axilla level and 2. Okay, and when you have a dissected axilla, suspected residual microscopic or macroscopic presence there. Okay, in some regions, after we have a microscopic or a macroscopic suspected macroscopic presence there, or undissected axilla because of the sentinel node biopsy, and just only the sentinel node biopsy only, and recommended in the pattern who has undergone sentinel node biopsy alone but not met the Z11 criteria. Okay, so the T3 tumors more than 2 positive nodes, if axillary dissection will not be performed. Okay, these are the areas where we can really think about the axillary level and 1 and 2. Consider the patients similar to those enrolled in the AMROS trial, and 2 positives like with the sentinel node biopsy. However, it is unclear if these patients requires formal coverage of undissected axilla. Consideration should be given. It's also included to supraclav with IMC irradiation in these patients. That is more important to clearly understand. But still, these are really gray areas, but it depends upon what guidelines you try to follow. And you need to have a standardized guidelines for every institute as well as for every country. Regarding the internal memory chain, the one thing, most of the times, like, we always believe the internal memory chain is not a big component in the regional nodal irradiation. But, the internal memory chain is a major lymphatic drainage pathway for the breast, which is about 25% of the breast lymphatic system. But including IM nodes will always, will help to reduce local recurrence, and it reduces the distal recurrence, and slightly there are some evidence which improves the survival. But obviously we need to consider, as when you give a radiotherapy, we are going to increase the cardiac toxicity as well as the lung toxicity. So that this is an just I picked up for the IM node. The IM node recurrence, which has an there is an always when you do a neoadjuvant chemotherapy, normally 80% of the IM nodes have been taken care. Okay, so that when you go for this patient, there are 353 patients which node positive, like somewhere around IM, which is somewhere around 148 patients, and they have a relapse of something about 20%, which where they have given an IM radiation, and normally the neoadjuvant chemotherapy plays a major role here. Okay, and internal memory chain and RT is it's the failure pattern. When you see the failure pattern of the internal memory lymph nodes, normally we have to be very careful when to give the internal memory chain, when not to give the internal memory chain. Okay, let's start with this radiotherapy planning. When you do the CT simulation, when you intend to give an regional nodal irradiation along with the whole breast or mass chest wall irradiation, always when you think about supine, that's the standard practice we follow in our center. We can add with a breastboard or a wing board. Normally we have a CT slice something about 2.5 millimeters. Turn the face towards other side. Just we can avoid part of an esophagus, and spinal cord. And contrast can be considered for the, it will really help us to understand what is the current situation. Sometimes, we can pick it up some positive notes, after chemotherapy, always this contrast can help you when you try to give an regional irradiation. And long neck and short neck patients require some special care because the anatomy of these patients who really have a difficult challenging in the radiotherapy planning. Obviously, when you prefer a regional node irradiation, whether it's an axilla, supraclav, or internal memory chain, always CT-based planning is a preference because it will help you to evaluate the plans quantitatively and qualitatively, and it will also help you to understand how homogeneously these targets are covered, and we can have a graphical and statistical representations. Okay, so that CT doesn't really optimize, we can help us to optimize the treatment plan and able to give a more homogeneous to the target and reduce the doses to the OARs. Okay, let's start with beam arrangements in the radiotherapy planning. Normally, the three-field arrangements when you start with half-beam block, using a single isocenter technique, and two tangential field for the breast, and two field for an or axilla and supraclav if you are intent to treat the level 1 and level 2, if you can add an posterior axilla, or otherwise if your intention is just to treat a supraclavicular and level 3 of an axilla, just a single field is more or less sufficient to cover the axilla and axilla level 3 and supraclavicular nodes. And field in field and low weighting and enhanced dynamic wedges will be helped to have a more homogeneous distribution around your targets. Let's start with the single isocenter technique. Normally, we place an isocenter so that we'll avoid the beam divergence between the supraclavicular field and the tangential field. So that the isocenter is just used to both for the tangential. Same isocenter will be used for both the tangential and the supraclavicular field. And the tangents have the half beam blocked in the superior, so in the supraclavicular half beam blocked inferiorly to avoid the overlap between these two fields. And the collimator of the tangent fields typically set if normally we don't rotate the collimator rotation. If you rotate the collimation, try to block the divergence pattern with the MLC or using a block. Okay, the isocenter position, selection of the isocenter position is very important when you go with an single isocenter technique. Normally, it's just a few millimeters below the supraclavicular node, and check where the PTV changes significantly. You can see this, there's a supraclavicular node, and suddenly just, it's coming out here. So that the normally, we keep just 1 or 2 millimeters just below the this is the supraclavicular field you can see in the red, and just we can keep 1 or 2 few millimeters just below the supraclavicular node. We can keep our isocenter position. The selection of isocenter is very important to have a very good plan. So that in a single isocentric plan, you keep the isocenter here and open your MLC. This is just I'm putting an it's an traditional standard fields without the contouring. I'll show you how it changes with your contours. Okay, so that this is traditionally how you treat a supraclav with all the 3 level of axilla as well as the supraclavicular field, and you have a tangential field which we can just shield the lung as well as the heart, how much you can do in the tangential field, and you can add an field in field method or an enhanced dynamic wedge method to improve your homogeneity between the breast as well as in the supraclavicular and the axillary nodal area. Okay, so this is a single isocentric wave, how it, for a single isocentric technique, how you treat an supraclav plus axilla as well as your both the breast with the tangential fields. When you go with the dual isocenter, okay, most of the times, I prefer to go with a single isocenter technique. When you don't have an asymmetric collimators in your center, when you try with the cobalt machine or a linear oscillator which doesn't have an asymmetric collimators, obviously you don't have any other choice. You have to go with a dual isocenter technique. So that you have to put a supraclavicular field, and when you put a tangential field, and obviously you can see the red which is an hot area and the shade area which is an cold area, which is always going to be a problem. So that the dual isocenter technique, normally what we can do is just, tilt the couch such that both the tangential field just, will merge so that you don't have a divergence of the beam, as well as you can put a supraclavicular field with an, a central shielding so that it will have an asymmetric field here, so that there'll be no divergence between these two junction of the supraclavicular field and the tangential field. So that in a dual isocenter technique, so that you can use something like this, and you can just rotate your couch rotation such that you can avoid the divergence. Okay, what It's like what it looks like, when you don't do the contouring of the level of axilla, when you give a standard field, when you have an large volume centers, most of the centers follow. Okay, just you go with the traditional fields, standard field portals, like for the breast as well as the axilla and the supraclav. Normally, when you put a field like for this is a supraclav level 1, 2, 3, and you put a standard field, normally we end up in we most of the times the outcomes were really very good. We have this is how we treat for last 2 decades. Normally, if you go with an with this journal with this reference, 84% of the level 1 of the lymph node which is covered by 45 gray when you prescribe 50 gray, and 88% of the level 2 which is covered by 45 gray volume, and 93% of level 3 is covered by 45 gray volume, and 84% of the supraclavicle node and 80% of the IM node is traditionally covered when you put in standard portals. But obviously we have an keeping the normal tissue and the toxicity mind, we can really improve the homogeneity of the target, and we can improve the coverage of this level 1, level 2. Okay, so that as we earlier discussed about high tangential field. When you try to give an high tangent field, normally in this case, like if we give a 50 gray in 25 fractions, the axilla covers 78% of level 1, 45 gray volume covers 75% of level 1 and 21% of level 2. And if you try to do a little bit of a customize in your tangent, we can make sure 100% of your level 1 will be covered like a 45 gray, and 95% of your 45 gray volume of the level 2 will be covered by 45 gray volume. That is good enough, so that just using a customized tangent, we are really able to improve the level 1 and level 2 when there is whenever there is indicated. So that when you put a standard field, like when you don't do the contouring, this is what going to happen. Like if you can see here, okay, the level 4, which is the supraclav, and the 3 levels of the axillary node, and this is an humerus PRV. You can see there is a little bit of an under coverage for the level 1 axilla. You can see here. So that this is the reason why we need a contouring based regional node, regional node irradiation when you want to treat all the axilla, level 1, level 2, level 3, which is really going to be difficult when you go with the standard landmarks. Okay, always, if when you are trying to do a regional nodal irradiation, always try to do and contour and make sure, all the 3 levels has been properly covered. And this is like, when I do the contouring, I make sure, all these levels has been covered properly. Okay. But regarding the posterior axilla, I think there was a question why we require a posterior axilla field when you want to do a posterior axilla field. Okay, if this is the case, when you want to do a single field, you want to try to cover all the 3 level of axillas, level 1, level 2, and level 3, and the supraclav. You can see an amount of when you try to cover around 95% of the level 1, we are covering something about the entire apex is going to receive a lot of dose. The entire apex of the lung is going to receive a lot of dose. So that just in this scenario, when you want to try to cover level 1 and level 2 axilla, just giving a posterior field with a little bit of a small weightage, you can able to reduce the dose to the apex lung. So that this is a scenario when you will use a posterior axilla field when you want to try to treat the level 1 and level 2 axilla, which is really the posterior axilla field is going to improve the homogeneity of all the 3 level of axilla and is going to reduce the dose to the apex part of the lung. And the chest wall irradiation, and regarding the chest wall irradiation, normally there is always an advantage of using an electron in the chest wall irradiation. Like in the supraclavicular field, you can use a photon field, and in the electron field, and you can use for the chest wall, you can use an electron field. If IM field is indicated, then you can use a different energies because the chest wall thickness is going to be different, and then internal memory chain field is going to have a different thickness, so that we can use different energies for IM field as well as for the electron chest field. So that chest wall irradiation, like really the electron. And you can use a combination of electron and photon combination, but you need to be a little bit careful. I talk about the junctions problems. Okay, we need to be really careful what you have to do. Okay, this is a typical patient, where you required there is an indication of an intramemory, like an internal memory node, and you have a chest wall, and you need to treat a supraclavicular node. Okay, so that normally we give a gap. Okay, like I will talk about this gap in my following slides. Okay, when you have an electron-electron junctions and when you have an electron-photon junctions, what is going to happen? We have to be clearly understand. Okay, so that this information is really going to help to reduce the hotspot, or otherwise this junction is going to be a very crucial area when you do an electron-electron or electron-photon junction. Okay, when you choose an electron energy for this, the simple calculation is, if you want to treat a 3 centimeter of a tumor of an internal memory chain, just multiply by 3. Normally the ideal energy to treat with for is around 9 MeV. I think the same principle for the chest wall. You want to treat for a 2 centimeter depth of the entire chest wall, just you multiply by 3. The 6 MeV will be the ideal case for the chest wall, and you can use a 9 MeV for your intramemory chain. And if you have a 6 or 10 MeV photons, you prefer a 10 MeV photon in the supraclavicular region. It's a typical distribution when you have an IM as well as the chest wall. Like when you have a junction between the electron field, this will be the typical junction. You'd have a very good coverage on your chest wall, as well as you're giving adequately dose to the IM nodes. Okay, the electron and photons for the IM node junction. Okay, this is a little bit, you need to be very careful. Like when you give a photon field for the tangential fields, and you're trying to put an electron field over here, you can see this space which is going to get a very cold. So that we need to be very careful, whether if the tumor is very close to this junction proximity, we need to be very careful, so that planning this divergence of the beam is very important. How you match this junction between the electron and photon is very important. And don't try to match this junction when you have any if the tumor is very proximal to this region. And this is a whole burst with an IM radiation. You can give a small electron as well as a photon beam junction, and there's a small hotspot here, so that that's how it is. Always when you have an electron and photon junction, you always end up in a small hotspot over there. But you have to make sure that hotspot is not more than 100 and 110 and 120%. And the obliquity of the electron beam resulted in a lot of hot spots. Okay, so that always when you try to go with the chest wall irradiation, make sure just the electron beam is just perpendicular to your chest wall, so that if you just have a more inclined angle, you're going to increase the hotspot in the periphery, so that which can end up something about 130% only because of the oblique incidence of the electron beam. And when you try to do an electron portals, you need to be very careful. The penumbral margin for the electrons are much higher compared to the photon beams, so that you need to give an additional 1 centimeter margin. And when you try to do an electron-electron junction, when you have a 9 MeV beam as well as a 6 MeV or 7 MeV beam and 18 MeV beam, when you this lateral bulge, okay, because we used to call as a ballooning effect. Okay, when you do with the two junction, when you have a two electron beams, which is going to give more hotspot compared to an electron and photon field. So that if you see an electron and photon field, if you do a junction, just you can end up with somewhere around 120%, or it's a small volume which is receiving 120%, and more or less you have an homogeneous coverage around that. But when you do an electron-electron junction, if you give a 1.5 centimeter gap, you get at the depth, you'll get something about 100 120%. When you give a 1 centimeter gap, you will end up in something about 130 to 140%. And when you give 0.5 millimeter gap, you will end up in more than 140, 150%. So that we need to be very careful when you do an electron junction matching compared to an electron photon junction matching. And regarding the toxicity, with the different trials, when you try to do a regional nodal irradiation, especially all the 3 levels of axilla, obviously there is an increase of pneumonitis, and with all these trials. And when you talk about the lymphedema, the main the risk, obviously there is an increased risk of lymphedema with regional nodal irradiation, especially for the if you take the entire 3 level of axilla at the supraclav and the obviously there is an increase in the lymphedema with the regional nodal irradiation. Regarding the hyperfractionation in regional nodal irradiation, still there is a lack of randomized evidence to support the use of hyperfractionation in regional nodal irradiation. But still there are ongoing trials or some of them are in the completed stage, but still we don't have enough evidence, randomized evidence to support the hyperfraction and regional nodal irradiation. And you need also to be considered when you go for regional nodal irradiation, you're going to treat a lot of volume with 2.6 ray per fractionation. So that when you try to treat all the level of 3 level of axilla and supraclav, you need to be very caution to go with an hyperfractionation. Better to go with a conventional fractionation of 50 gray in 25 fraction, which will be less toxic compared to your hyperfractionation and regional nodal irradiation. So that my take-home message is selection of regional node for irradiation is purely based on guidelines and evidence. So that as a radiation oncologist, you need to know clearly when you want to treat and when you should not treat. Make sure all the area of nodal target nodal volumes receives appropriate homogeneous dose distribution as much as possible. And your recurrence patterns, always this evidence which gives you a clear idea where this regional recurrence happens, so that you need to take care of that area very carefully. And single isocenter technique will make your life easier for a technologist and the throughput of a machine, so that if you put a dual isocenter, always it is going to increase the treatment time and it's going to decrease the accuracy of your treatment. Need to be really careful in electron field junctions, and double isocentric will be more laborious and it's to be more time consuming. When you intend to treat level 1 axilla, posterior axillar field will be required to cover up and reduce the apex lung dose. Thanks again for our kind attention. Thank you.
Thank you, Karthik. So I didn't put any conclusion slide at the end of my presentation. I was waiting for Karthik to say. So, what I want to say with Karthik, that what we need to think when we are treating breast cancer, either breast conservation or mastectomy, that conventional tangent is not taking care of our axillary nodal radiation. Hardly it is taking majority of the level 1, but not at all about level 2, what we have shown. So the moment we want to think of even treating level 2, we need to modify the tangent by as per contour, or we need to make a high tangent that is up to the level of the humeral head or 2 centimeter below. Something we need to modify. And number 3 is whenever the question of axillary radiation comes, it comes level 1, 2, and 3. So we need to add supraclavicular field. And when we are putting supraclavicular field, this is covering not only level 3, supraclavicular, invaclavicular, and also level 4. So all these are coming automatically when we are treating supraclavicular. So when we are talking about RNI or axilla, we need to be very cautious. Actually, what is our target? Is level 1, 2, 3, 4, or an IM is a totally separate thing. And as Karthik said, posterior axillary boost, it is not a very routine practice. If it is a very deep-seated tumor and we are not achieving adequate coverage, then a very small percentage of dose, not the whole 2 gray, very small percentage of dose is sent from the posterior axillary field, and it is a very tiny field. Because if we are not handling it properly, again, it will be a curse, not a benefit. So if it is, we are not covering with the 3 centimeter depth with the anterior supraclavicular field, then only we are using this posterior axillary boost. So this is actually the summary, and there are some gray zones, but as a clinician, I need to know what I want to treat. Do you want to treat level 1, 2, or I want to add 3, or I want to add IM? If I want, I must have my logic behind it, like what outcome we are expecting, what is the tumor biology, what is the extent of surgery was done, whether there was NSCT was given. So many issues are there. And again, as we said at the beginning, that this is a gray zone area. Nodal irradiation in breast cancer is one of the most debatable areas still. And most important thing is what I believe, when I started my career, I was taught the most easy treatment is breast cancer treatment. 3 field, 2 tangent, 1 supraclav, done. But now I realize at this age, the most difficult treatment is breast cancer, because to ensure that you have really covered the target with the nodes, it is very difficult. And it is not always, we are not practicing contouring. Sometimes we are basing on this bony landmark and we don't know what we are doing. Are we really curing a patient, or we are doing some lymphedema? So this was my comment, my summary comments on my presentation and Karthik's presentation. Still, we can take few questions, even we are out of time, but I think we should take some question on Karthik's presentation. And thanks, Karthik, for the presentation.
Thanks, Kamal.
Questions? Any question? If there is no question, can I share the screen and we will go to the, so we'll ask, sorry, Masoom, can you give the review of last week?
Yeah, sure, sir. So we can, it's, okay, thank you, Council. So, Assalamualaikum and very good afternoon to all of you. I'm Dr. Masoom, back with some statistical facts and statistics of our previous session. Session was on breast surgery, what oncologists need to know. Faculty was Dr. Sheikh Farid Ahmed sir. And we have already uploaded our session, that session to our YouTube channel. So if anyone missed, so they can get it at your convenient time. Here's some statistics of the last session. Participation rate was good; it's almost 100%. But one area we have facing challenge from the very beginning, that is feedback. Feedback rate is not up to the mark yet. So I am requesting all of you to please send us your feedback. Here's some. This is result analysis of our last session. It's showing some heterogeneity, and high score was 90, and average score was 46.5. This winner, Dr. Altaf Hussain, he was the winner of the seventh session. Probably he won the award for the second time, I guess, second or third time. So there is a session comparison of all of our sessions. I'm not going thoroughly with busy slide, but what I want to highlight, which is easily visible, that consistent and consistent positive development of our each and every parameter except the feedback, which I mentioned earlier. So that's all from my part. Back to you, Thomas, sir. Thank you.
So thank you, Masoom. So if we go, so now it is the quiz time. So Regan, will you put the quiz on the chat box? And regarding the feedback, we are working to redesign the program about the timing, duration, and the day, and your feedback, and also about the selection of the faculties and the topics. So your feedback is very important. Please try to give some feedback so that we can really work on it. Regan?
And one thing I want to add is, if you have any feedback regarding our feedback form, please let us know.
Okay, so the quiz is given to the chat box. Please join the quiz. So by this time, when we are going for the quiz, somebody get ready for the rapid fire session. There will be 10 questions. Very easy question, I believe. And today I see the participation was not like before. It is near about 50. Maybe the surgeons were not very much keen, but they knew that we will have so much surgery discussion. They thought it will be a solely radiotherapy discussion. So during this quiz time, John, would you like to make some comments? Because we had so much discussion about the gray zone, and I mean how you handle, in your cases, how you are handling.
I think it's clear from today's discussion that when it comes to the selection of nodal volumes to irradiate, that you really have to consider the patient and the patient's tumor biology, comorbidities, life expectancy, and the complications, the long-term morbidity of irradiating these different areas. So I'd say, you know, there's clear-cut cases, but where you will include the SCF, for instance, and the axilla. But the longer I do this, I realize that you do need to, just like when you discuss your patients in MDT, you need to optimize the treatment for the patient in front of you. And I think it's important as well to share the risks involved of those treatments, yes, because it's the long-term consequences of, for instance, SCF and IMC irradiation, and it's easy and low toxicity typically as the patient goes through it, but then 3, 5, 10 years down the line, when you're still following these patients up and perhaps you then begin to see some of these late complications, it's ensuring the patient's fully educated at the point of consent when you begin this treatment strategy with them, so they're on board for the long haul. But I thought today's talks, you know, as ever, really comprehensive, very detailed. The focus obviously is on the evidence, and I think the discussions they generate are really useful, you know, because it is such a controversial area, you know, where maybe there is no right answer. So you really have to balance the risk versus benefit.
Thanks, John. So that is, we can say that there is no clean-cut answer for many situations. And as you said, breast cancer patients is a big, long survivor. So now we not only think about the disease, we need to also think about the quality of life. And as you said, we need to really focus on the long-term side effect, because we are always considering what the short-term side effect. But these people, we are thinking of maybe 20-year survivor or 25-year survivor. So those patients, and normally, I think the heart is a big area where still we really don't know that what is the critical dose and how we are going, what is the, minimum effect that is going on heart. So that is a big area, and even the brachial plexopathy and all these things, it may come up very late. So really we don't know. For the small survival, shall we take the risk or not? Again, on the other way around, the heavy burden patient, shall we exclude it and miss the chance of this survival? So this is a good area. Thank you for the good discussion, John. So we are almost at the end of the quiz time. Yeah. So we, during they prepare the result, we go for our rapid fire session. So any volunteer, please. If you volunteer, you will get 10-point bonus, which will 100 bonus will give you another award. Anybody? Please quickly come forward. Somebody. I need a volunteer, please. Nobody?
Kamal bhai, should I suggest?
Yes,
Kamal
please.
bhai?
Yes.
Dr. Kajol.
Dr. Kajol. Are you there, Dr. Kajol?
I have seen his name.
Dr. Kajol, you are here.
Sir, Assalamu alaikum.
Okay. Yeah. So I know you. Okay, let us start, Dr. Kajol. The first question, Danish 82B and 82C trial was designed for which group of breast cancer patient? Which group for 82, which group for 82C?
Sir, premenopausal and postmenopausal.
Thank you. Yes, very good. You see, the questions are very easy. British Columbia trial published data of how many years outcome?
Sir, 5 years, as far as I can recall.
Sorry, it was 20 years follow-up.
Sorry.
Okay. So what was the mean number of nodes dissected in Danish trials, 82B and 82C? Mean node was 7. That was the that is why we criticized them that adequate dissection probably was not done. Okay. So this meta-analysis 2014 have shown level 1 evidence of improved outcome in which node group of breast cancer?
Sorry, sir. You want this?
They have shown that level 1 evidence of improved outcome by adjuvant nodal radiation. In which group? 1, 2, 3, 4. Which group?
Sir, post-mastectomy level 1 and 2.
No. Which group of nodes patients? Level node 1 node positive, 2 node positive, 3 node positive, 4 node. Which group was beneficial? They have shown.
How many node was positive?
And which group? Say node positive, say 1 node positive was benefited, or 3 node positive, or 4 node positive. Which group?
Sir, in one group, sir.
So they said that both 1, 2, 3, and 4, both group was actually benefited. Okay. So we go for next question. This EORTC phase 3 trial, this showed significant benefit of DFS or OS.
Sir, DFS.
This is a newer trial.
Sir, DFS. Disease-free survival.
Yes, it is. They have shown the DFS benefit. In Z1 study, how much percentage of patients found to have high tangent or supraclavicular field during evaluation? We had discussed it. That was the big caveat in the total Z1 study, that 50% of the field patient had high tangent or supraclavicular field. So what is your target for supraclavicular field treatment? Which group of nodes you cover in the supraclavicular field?
Sir, level 3.
Level 4.
Level 3. 4.
Level 3, sir.
Only level 3.
3 and 4.
Yes, level 3 and 4. Also supra and infraclavicular nodes are there. Very good. So in NSCBP 18 and 32 study, observed in PN plus after neoadjuvant chemotherapy in NSCBP 18 and 13. How many percentage of patient recurred? Local relapse was there.
Sorry, sir, I cannot recall.
So it was 15%. That's why this is a evidence of giving adjuvant nodal radiation after residual node after NSCT. So in MD Anderson Cancer Center experience, which group of patients were benefited from adjuvant RT after NSCT? They said that stage 3B and 3C were the benefited. So what was the 10 years outcome of Amaros trial? What was the conclusion of Amaros trial 10 years after 10 years? What they have concluded?
Sir, lymphedema was higher in surgery group.
And it was 5 years outcome. What about the 10 years? They have concluded, they have given a landmark conclusion.
Sir, no difference between the surgery and the nodal radiation.
No significant difference.
Yes, there were in axillary recurrence, distant metastasis-free survival and OS, there was similar in both axillary radiotherapy and ALD arm with higher lymphedema in, ALD arm, I said axillary arm. So, thank you. See, you are not coming up, but when you are coming up, you are doing wonderful. So, you have done almost 85% correct answer. Thank you. Congratulations. So,
thank you,
do
sir.
we have the answer? So, we have the name of the award winner. The name is Dr. Saiful. He has done 80 out of 100. Is it you, Saiful?
Yes, sir. Saiful Alam Kajal.
Okay. So it was a good selection. We selected you, and congratulations. You have done a great job. You have made 80 questions correct out of 100, 8 questions correct out of 10. Congratulations. So you have done a great job. So
thank you, sir.
Now we are almost at the end. I want to say that it was as expected. It was a very lively discussion. We had very good discussion, big participation, and finally we concluded there is no conclusion. We need to take our own call, but it should be evidence-based, it was judicious. So I see that today we have the representative of Sanofi there. Would you mind, Lucky, to say very quick vote of thanks because we are running out of time.
Thank you, sir. I am always feel honored and privileged to have the opportunity to give vote of thanks. Dear Honorable Chairperson, respected overseas guests, faculties, speaker, distinguished doctors, and other healthcare professionals. Greetings from Sanofi, Bangladesh. I would like to express our profound gratitude to our Honorable Professor Muhammad Abdul Hai, sir, President of Oncology Club, for his gracious presence and opinion in this seminar. Heartiest thanks to Dr. Karthick Raj Mani, Consultant Medical Physicist, United Hospital, for his excellent and elaborate presentation on nodal irradiation in breast cancer, which is well discussed in the session. A special thanks to the Dr. AFM Kamaluddin sir for taking this initiative to organizing such lively interactive session and sharing the relevant treatment modalities through different studies. On behalf of the Sanofi, I would like to extend a very hearty vote of thanks to all honorable foreign delegates who blessed us with their gracious presence. Heartiest thanks to Dr. Mohammad Zakirullah, Dr. S.K. Farid Ahmed, and Dr. John Kinubier for their expert opinion. Heartiest congratulations to today's winners, Dr. Saiful Alam Kajal. On behalf of Sanofi, I would like to give a special thanks to all participants for took up their valuable time from current busy schedule. We highly acknowledge your support and contribution to our society. With all of your support, we will continue this program in future. Till then, stay safe, stay healthy. Thanks for patience hearing. Thanks to all.
Thank you, Lucky. So our next week, the presenter will be Dr. Taposh Mitro. This time, we are going to get a faculty outside Dhaka. He is Associate Professor of Department of Radiotherapy in Chittagong Medical College. He will be talking on endocrine therapy in breast cancer, and we are expecting all the 3 foreign faculty to be there. And we will have some more session following metastatic breast cancer, post-mastectomy radiotherapy, and uncommon histopathology of breast cancer, or anything you want. So this is all. So by giving thanks to all the participant, foreign faculty and local faculty, I want to end here. Our President, Professor Hai, had to get disconnected due to the load shedding. So apology from his end. Thank you.
I've already joined.
Oh, sorry, you joined. Thank you. Sorry,
yes,
sir.
I've already joined.
I get it. Sir, can you please end so that we can finish, sir?
Okay, we had a very nice discussion, although it's later part I couldn't listen anything, I couldn't watch anything. And my heartfelt thanks to all of you. I hope to see you next session.
Thank you, sir. So it is a wonderful experience we are having every week. We are learning many things. Every week we are getting enlightened, and we are enjoying, and hope you are also enjoying with us, and you are getting benefit out of it. Oncology Club is always with you, and hopefully will be with you. See you next week. Till then, stay safe and enjoy.